Okay, let's start. We have about 13 cases. So for those of you who entered the room lately, please connect to the Wi-Fi of the ECR. It's room A, so you have the choice of the Wi-Fi ECR room A in order to be able to vote. We will check the causes of pitfalls in ultrasound that may be due to problems or errors in technique, in interpretation, or patient-related limitations, such as anatomical limitations, inadequate phase of the cycle, or limited sonographic access due to a large mass, pain during mobilization of the probe, or the Virgo status of the patient. Sometimes certain diseases can contain air or calcium and produce posterior shadowing, which may enable the evaluation of the mass. The lesion can be located very posteriorly and has to have limited access. Now here's my first case. You have a 20-year-old patient with dysmenorrhea. This is an excellent sagittal imaging plan. So my questions are, is this adenomyosis, a normal uterus, or fibroid? Please vote. Okay, can I have the answers, please? Okay, so let's see. This is actually a normal uterus, and what you see behind the endometrial lining is just posterior endometrial enhancement due to the more hydric nature of the mucosa instead of the myometrium. Now here you have on the top a sagittal image where you can see that the hypoechoic lines are filled with color, so these are just the normal uterine veins. You have below a sagittal image of the cervix, which shows you a normal upper vaginal and rectal wall in a sagittal view, which you should always assess, because then you can identify potential abnormalities for endometriosis. And adenomyosis at ultrasound has a quite different appearance. You have hyperechoic areas that can be linear, or it can be perpendicular to the endometrial lining. You can have also these hypoechoic little round structures which are typical of the bloody cysts. Now this is adenomyosis at ultrasound. Now let's go to the second case. I show you 4 patients. Patient A, a sagittal view, an axial view. Patient B, a sagittal view, an axial view. Patient C, sagittal axial. And patient D, sagittal and axial. Now this is my question. Which patient has an endometrial polyp? All? None? A, B, C? Or A and C? Please vote. You have the chance here of some fluid inside in patient B. Can I have the answers, please? Okay, this is not bad, but actually it's A, B, and C. So A and C are the classical appearances of polyps, okay? What we see in patient D is hypoechoic. It has peripheral color Doppler, so this is typical for a submucosal fibroid. Now in patient B, that's the tricky one. You see the fluid that hints you that there is a localized thickening of the endometrium. Okay, this could be potential adhesion, but this could also be a polyp. So if the patient is complaining about hemorrhagia, she needs to undergo a hysteroscopic examination and removal of the polyp. This is patient 3. She complains about amenorrhea and bilateral adnexal masses. I show you first the transabdominal images, sagittal and axial. And now you have both adnexa. Here, the right one, sagittal images, axial images, and here the left adnexa. So my questions are, actually both sides have the same pathology. Are these functional cysts, mucinous cysts, endometriomas, or hematosalpinx? Please vote. It's not easy when you don't perform the images and they are static, but I try to indicate always if it's a sagittal image and in what part of the pelvis it's done. That's the left side, that's the right side. Can I get the answers? Not bad. Actually, the right answer is hematosalpinx. So why couldn't those be endometriomas? Let's check where the ovaries are. I told you that both pathologies are similar. Now here you can see an ovary. This is a vasculate structure. Here you have a nice ovary. Maybe there is a functional hemorrhagic cyst, but the problem are those structures here on both sides, which are blood fluid. And the thing is, you can see this small incomplete septation. Now this is the hint that shows you this is something of a tubular structure. It's independent from the ovary here. And you can see something that has a tubular structure here. It's also some septation. Now it's not easy, I say, and I performed an MRI in order to get the right answer. You can see the tubular structure here, which is separate from the right ovary here. The left ovary is here, separate from this multicystic structure, which got stick to each other. And it's much more complicated to say that this is a hematosalpinx. But there are signs that are typical for a tubular origin of a mass. The famous waist sign, if you have a cinturon around your waist or a belt, like here, the incomplete septa. And of course, here you have on the T1 weighted images the blood within the tubular structures. Now, on ultrasound, the best sonographic sign for a tubular origin is this famous waist sign, or the belt around the tubular structure. But this has a likelihood ratio of about 20, according to this nice paper published by Patel in 2006. The tubular shape has a likelihood ratio of 10. Incomplete septation, such as this, likelihood ratio of 2. Small round projections, 2.7, and the half waist sign, that only one of those little indentation, 3.5. Now, a tubular origin can also be diagnosed if you have an association with this short linear projection and a tubular shape, likelihood ratio 6.3. And of course, the punctuate liquid can be either blood or pus, and in this case, it's a hematosalpinx. Let's go to the next case. I show you 3 different patients, and I want you to choose which of those patients has an ovarian teratoma or a bowel loop. So this is patient A, axial sagittal, 2 orthogonal views, patient B, and patient C. So the patient with a teratoma is patient A, patient B, or patient C. Please vote. Can I get the answers? Okay, very good. So why it's patient A? You can see that there is a hypoechoic mass, which is the first characteristic of a teratoma. And it's, of course, of ovarian origin. You can see the ovary here with some follicles, and particularly ovarian parenchyma, which is surrounding the mass. And this is the typical claw sign, which gives you the hint that this is not something originating from something else than the ovary. It's not a bowel loop attached to the ovary. This is different for patient B. Here you have a CT that shows you the contrast-filled small bowel all around a tiny, small, normal ovary here on the right side. On the patient C, you can see that there is a sigmoid bowel that sticks to the ovary on the MRI images, and this is one of the reasons why this only corresponds to the normal ovary, and this is the bowel. But however, it's tough to say. However, if it's so hypoechoic and no posterior shadowing, this is not a teratoma. Now, GI pathologies mimicking adnexal masses are quite frequent. They could be diverticular. Here is a diverticular fluid filled with air, so you get this posterior shadowing due to the air. Here you have a thickened diverticular of the sigmoid, so this is diverticulus. And you have, in this patient, an abscess posterior to the sigmoid, which is definitely not something connected to the ovary. Now let's go to case 5. Here we have a retrouterine cystic masses independent from the ovaries. It's in a 62-year-old patient with hormone replacement therapy that complains about chronic pelvic pain radiating in the lower back. Now this is a difficult case. I show you images through the vagina of both adnexa. This is the right side and this is the left side. Here are my questions. Possible diagnosis: A, bowel loops; B, hematosalpinx; C, Tarlov cysts; D, all. Please vote. I told you they are independent from the ovaries, but on both sides of the uterus, posterior to the uterus. Can I get the answer? Yeah, that's it. It was really tough. It's difficult. So in this case, it could be all, because it could potentially be bowel loops. I agree. We have fluid. We have some feces could be here. We have also some thick material inside, something that looks tubular. Could be hematosalpinx. And it could be a Tarlov cyst. But what is a Tarlov cyst? A Tarlov cyst is a perineural cyst, fluid visceral spinal fluid, usually anterior to the sacral region between S1 and S4. And the walls are made of nerve fibers. You have the corresponding MRI. On T2, we have some fluid-filled structures. On T1, you can see them anterior to the sacrum. Here, you can see some of the nerves. And they are quite huge, and they can easily mimic adnexal masses. Okay? However, they're usually not responsible for the patient's symptoms. So let's go to the next case. What is the possible diagnosis for this retrouterine mass? You can see sagittal images here. You have the uterus here, the cervix, some color Doppler imaging. This is the pathology. This also here. So the possibilities are bowel loop, tubal abscess, neurogenic tumor, or ovarian teratoma. Please vote. This is a real tricky case. Can I get the answers, please? Very good. Of course, you all have seen that there is color here, power Doppler color, inside a solid portion of a mass. So this cannot be a Bauer loop. It cannot be tubal abscess, where we would see the color Doppler only in the periphery. And it's very rarely ovarian teratoma, which usually is not hypervascular. And we miss the predominant hyperechoic component and the posterior shadowing. So this is a neurogenic tumor. We can see here, again, anterior to the sacrum, a heterogeneous T2 mass. You can see it here on the sagittal image. And after contrast injection, it's enhancing exactly in the same way than the uterus. On a CT, we have some calcifications here. And this was a sacral teratoma. Now, case number 7. This patient has acute abdominal pain, metrorrhagia, and an irregular menstrual cycle. I show you transabdominal images and endovaginal images of both adnexa. This is the right side, again the uterus through the vagina, and this is the left side. I show you again some of the summary images. Now, what are your management decisions in this patient? You ask the patient for last normal menstruation and intercourse and check the blood pressure. B, you check the patient's body temperature and ask for a CT. And C, you ask the patient to come back after the next menstruation. Please vote. Thank you. Can I get the answers, please? Okay, very good. So let's go back. This is definitely a patient that needs to be checked for her blood pressure. You can see that she has a lot of blood or potentially pus inside her uterus. There's fluid around the uterus. The uterus is empty. She has irregular menstruation, so you cannot not exclude extrauterine pregnancy. And this is actually what she had. You can see on the left side, there's a normal ovary here, and here is a rim enhancement in a tubular structure attached to the ovary. Let's go back. You can see here a blood-filled tube with a hypervascular sign in the wall, which is quite rare that you can see the tube like this. On the other side, you can see a corpus luteum, and hematoperitoneum is the predominant sign. The rim enhancement here around the fetal sac is really something that gives you the hint, which is not as frequent. Now, extrauterine pregnancy is the first cause of death in pregnant women during the first trimester. 2% of pregnancies can be tubal, like in this case, or abdominal. Pain and metrorrhagia are present in 70% of the patients. The indirect sonographic signs are an empty uterus, a corpus luteum, and peritoneal fluid. And the direct sign, the hypervascular ring around fluid collection. But it's only seen in about 20% of the patients. So this is very good. Let's go to case number 8. We have a patient aged 31, deep dyspareunia, sagittal view and axial view transabdominally. Uterus is here. Now I show you endovaginal images, sagittal through the cul-de-sac. This is the cervix here. This is the cervix axial. You can see the ovaries. Left ovary. Right ovary. What's the diagnosis? Endometriosis of the vagina and the ovaries, cervical cancer, rectal wall thickening, or ovarian fibroma. Please vote. So that's the cervix here. Axial, sagittal. Answers, please. Very good. This is definitely endometriosis because you can these hypoechoic filling of some fluid-filled structures in the ovaries, no vascularity inside. They are bilateral, typical for endometriomas. And if you check this vaginal cuff, the posterior vaginal cuff, there is an abnormal vascularized structure with a solid portion. So this is typical for the vaginal location of posterior endometriosis. It's sticking to the rectum, but the rectal wall seems to be normal. However, it's quite tough sometimes to make this diagnosis of rectal invasion. So that's the reason why the extent of disease is usually determined by MRI. We use vaginal and rectal filling, so you can easily see the vaginal nodule, which in this case is not protruding into the rectal wall. The rectal wall here is totally normal. And this is the vaginal endometriosis. It's usually enhancing quite vigorously. Here are other examples of retrocervical endometriosis. Here is the cervix again. Sometimes it's at this place called torus uterinus, which is the portion where both uterosacral ligaments connect behind the cervix. And you can see also that those lesions extend to the uterosacral ligaments. If you do through axial images through the cervix, you can see lateral to the cervix those hypoechoic triangular lesions which sometimes grow into the rectum. And here you have on the other side also hypoechoic mass close to the cervix, which corresponds to asymmetric thickening of the insertion of the right uterosacral ligament. Usually, if you touch it and it's painful, it's endometriosis. Here you have an example of another nodule behind the cervix here. You also have to check the cul-de-sac between the bladder and the uterus for bladder endometriosis. And here you have another example of retrocervical endometriosis attaching to the rectal wall. In this case, rectal invasion is quite possible. Examples for endometrioma, they are usually very homogeneous. They are hypoechoic, but not as hypoechoic as mucinous tumor. And when you compare them to functional hemorrhagic cysts, functional hemorrhagic cysts are more heterogeneous, and they have this typical hypervascular ring around the corpus luteum. Another specific sonographic finding of endometrioma are these hyperechoic cholesterol deposits in the wall of the endometrioma. They are not very sensitive. You can usually find them in only one-third of endometriomas, but it's a nice sonographic sign. Let's go to case 9. Here is a patient that complains about deep dyspareunia at the age of 42. She has a history of subcervical hysterectomy for endometriosis and unilateral oophorectomy for endometriosis 5 years ago. So this is the image of the remaining cervix, axial and sagittal. Transvaginally again, through the cervix, sagittal. So what's the diagnosis? Is this endocervical cancer, hematoma post-hysterectomy, recurrent rectal endometriosis, or a peritoneal cyst? Please vote. Can I get the answers, please? Very good. So you attended your mind for this lecture, because definitely there is a mass attaching to the cervix, actually more lateral, and that grows towards the sigmoid, where you can see the folds of the sigmoid. Now, of course, we performed an MRI for more precise staging, which nicely shows that there is recurrent endometriosis in the anterior wall of the rectosigmoid, and that comes from the cervical scar. Here are other sonographic examples of bowel endometriosis. You can see nicely here the localized thickening of a bowel wall behind the cervix. This one is much thicker here and takes place between the space of a bowel loop, and it grows into the sigmoid from outside, and it doesn't come from inside, of course. Case 10. This is a 36-year-old patient with metrorrhagia after intercourse. She has 2 children born by cesarean section, and she has a normal pap smear. You can see a sagittal image through the vagina of the uterus, an axial image through the cervix, here again a transabdominal image, and a transvaginal image of the space between the bladder and the cervix. So here are my questions. Is this cervical leiomyoma, ectasia of cesarean scar, cervical cancer, or Nabothian cyst? Please vote. Can I get the answers, please? Perfect. So this is definitely not cervical cancer. Cervical cancer would arise from the mucosa here, and it's hard to see, but it can sometimes be seen on ultrasound, but not here. It could be a leiomyoma, but you can see it's hypoechoic, and it corresponds exactly to the place where usually you can see the scar of a cesarean section. Here you can see how a normal uterine scar looks like. It's a thin hypoechoic line that is in this anterior portion between the cervix and the uterine body. Now, in the case of ectasia, it's usually full fleet. It can look like a Nabothian cyst, but it's more peripheral, and it touches the uterine cavity. It starts from here and goes outside towards the wall. Now, what is important for the clinician is that you measure the thickness of the remaining stroma or myometrium covering this scar, because if it's below 4 millimeters, then subsequent pregnancy has a great risk of uterine rupture. So they can get repaired through hysteroscopy. Here you have an example of a Nabothian cyst that would be located lower down. And here this is the example of the axial image through this cesarean scar ectasia. Case number 11. We have a bilateral adnexal masses, and you can see the ultrasound images of the right side through the abdomen and through the vagina. Now I show you those of the left side through the vagina. Sagittal, axial, more oblique. So my question is, what's the diagnosis? Is this bilateral ovarian cancer, right ovarian cancer and a left hemorrhagic cyst, right cystadenophybroma and left ovarian cancer, or bilateral benign ovarian masses? Please vote. So this is the right ovary, and this is the left ovary. Left ovary. So the masses on the left we are talking about are very small, bigger on the right. Can I get the answers? Okay. it was a tough case. It was really tough, and I thought that MRI in this case would really help, because both were benign ovarian masses, but not on ultrasound. So you're absolutely right. You can suspect cancer on both sides. And you can see here that we have a cystic and solid mass, such as we can see on ultrasound. Although in ultrasound here, no color Doppler finding. So it is it is suspicious looking for vegetation inside a cystic mass, but you have a negative color Doppler. So this is first point. On MRI, the structure is hypo-intense, the solid portion, and we just saw that before. It's typical for cystadenofibroma. Okay. On the right side, it's a tiny mass, but however, the color Doppler is positive, so it's a solid mass. It could potentially be a fibroid. However, when we see this on MRI, cystic solid mass on the right, and on the left side, we have a T1 weighted images which is not bright, and on T2 it's heterogeneous. In both cases we need to inject, and then we can follow the dynamic uptake. Here you can see the uptake of this portion, which is the solid portion of the cystadenofibroma, which is uptaking much less than the uterus. But here, in this little mass, the uptake is very strong as the uterus, so it looks like it's cancer. However, it was a benign left stromal tumor, like a tecoma, so that can happen. The false positive results of MRI and ultrasound are cystadenofibromas, benign Brenner tumors, or sometimes atypical dermoid with little fat and large enhancing Rokitansky nodules. So please take into account that those pitfalls are common for ultrasound and MRI, and you never should tell the patient if you have typically looking ovarian cancer without positive color Doppler finding, oh my God, you have cancer, lady. Please be very conservative. So there is a mass that needs to be investigated, but don't talk about cancer if color Doppler is negative. Here, case 12, we have a patient that has a postmenopausal cyst. She had a history of breast cancer, 55-year-old, and she was treated by tamoxifen since 4 years. So she's still under tamoxifen. That's a sagittal image of her uterus. First question. Indicate the wrong answer. The sonographic appearance of the mass is A, benign, B, borderline, C, malignant. So what's the wrong answer? Please vote. Can I get the answers, please? Yeah, very good. That's the wrong answer. It's definitely what has to be called on ultrasound a suspicious mass. You have a solid portion with positive color Doppler findings, so that could be potentially ovarian cancer. So that's my second question. Indicate the wrong answer. I ask for a CT, an MRI of the abdomen and the pelvis, an abdominal CT, and a pelvic MRI. Please vote. Can I get the answers? Very good. Usually when you have an indeterminate mass, because I still call this an indeterminate mass and not a mass that is typical for ovarian cancer, okay? The solid portion is not huge. There is color Doppler, that's why it's of concern, and it could potentially be or a borderline or a malignant mass. Usually for characterization of an indeterminate adnexal mass, we perform MRI. And why not CT? I published a meta-analysis and a Bayesian analysis quite a lot of time ago in 2005, which checked on what's the value of a second exam after an indeterminate ultrasound, if you perform CT or an unenhanced MRI or contrast-enhanced MRI. What is interesting is when the color Doppler is negative, the likelihood ratio, the negative likelihood ratio is the best. It has to be below 0.2. Okay, and that's the only examination where you get it straight away, except for MRI, where you also have O2. So this means that if ultrasound is negative, you can stop. A negative ultrasound examination with color Doppler, you don't need to do anything more in a patient with a postmenopausal cyst. Stop, that's fine, it's benign. However, if it's positive, then the likelihood ratio goes up from 4 for color Doppler to 44 for MRI. And if you compare the post-test probability between CT, a positive CT, and a positive MRI, it increases by 42%. So MRI, contrast-enhanced MRI in a premenopausal women is definitely the best technique in order to increase your probability of ovarian cancer. Okay? In a post-menopausal women, the increase exists also, but it's less prominent, 76 to 95% post-test probability for ovarian cancer. Here are some ROC curves where you can see if you do ultrasound with color Doppler, of course, you get the lowest prevalence for ovarian cancer, so you can stop. However, if it's positive, then you get the highest post-test probability with ultrasound and MRI, and not with ultrasound and CT or ultrasound color Doppler. Here is an example, again, of the benign serous cyst adenoma. And you can see that in this case, it's not a cyst adenofibroma, because this enhancing portion actually does not correspond to being part of the cyst, but it's the normal ovarian parenchyma protruding inside the cyst, which often happens in postmenopausal women. So this is a common pitfall in ultrasound, where you see the normal ovarian parenchyma making a pseudo-vegetation inside the uterus. Now, the third question for this case is, what is your recommendation in a patient that has this type of image of her sagittal, of her uterus? Would you perform hysterosonography, hysteroscopy, endometrial biopsy, MRI, or follow-up? So she's under tamoxifen since 4 years. Please vote. She also has cervical stenosis. Can I get the answers, please? Very good. However, I would say you should not perform endometrial biopsy by itself. Usually you should perform it under hysteroscopy in order to be able to target the lesion. If you perform endometrial biopsy in a patient with cervical stenosis, it's first very painful. You can't go through the cervix easily. So you have to do that under anesthesia and, of course, with a targeted view. The false positive rate of endometrial biopsy for cancer in these patients are bigger than 10%. MRI now is becoming an interesting option because of the diffusion-weighted images that can make a diagnosis between benign and malignant endometrial findings, which is quite new, but there has not been enough studies and enough cutoff values published in order to make this a current technique, but it's becoming more and more interesting. Hysterosonography would be difficult in a patient with cervical stenosis to introduce actually the the tube for the filling of the endometrium, and it doesn't give you something. However, in this patient, why? Because she had this cyst, she also underwent MRI, and you can nicely see the polyp here, and also the submucosal leiomyoma. She also has this benign serous cyst adenoma. Now let's go to the last case. This is a 36-year-old patient, again with dysmenorrhea and a history of endometriosis. These are transabdominal images. Again, axial on the right side. Here you have a transvaginal of the left ovary. And here you have the color Doppler findings of the right ovary. So my question is, which management option is not appropriate? CT, MRI, surgery, or follow-up? Please vote. (36-year-old dysmenorrhea, history of endometriosis). Can I get the answer, please? Very good. So this patient should definitely not undergo follow-up. That could be a dangerous position. Let me just check what I have here. If she performed MRI, you can see hyperintense tubular mass. That's the ovary, so it's also in the ovary. That's the other ovary. Here is the other mass. These are T2 weighted images. Now I show you the right adnexal mass on T2, T1 fat set, and T1 without contrast, and T1 with contrast. I did a dynamic examination. You have the uterus here on T1. Here is the right adnexal mass, and you can see the curves. This is the curve of the myometrium, and this is the curve that goes through the solid portion of that mass. Here is the left adnexal mass, T2, T1 fat set. Now, what's the final diagnosis? A, she has right and left ovarian cancer. B, ovarian cancer left and endometrioma right. C, ovarian cancer right and endometrioma left. Or D, bilateral endometrioma. Please vote. Can I get the answers, please? Very good. So that's it. She had right ovarian cancer and left endometrioma. It's definitely highly suspicious when you see a patient that has this image on ultrasound. It's definitely cancer. Okay? But because of her age, you can't, my 36-year-old, I could have sent her directly to CT for staging, because this looks like. But because she has a history of endometrioma and she has the other side, I prefer doing an MRI that allows to do both characterization of both masses and staging of the upper abdomen. However, in this patient, the cancer arising within an endometrioma is a rare possibility, but it can happen. I prefer to use, when I have a solid portion inside an ovarian mass, to do a dynamic examination where we check the contrast enhancement of the myometrium when we compare the curve to the myometrial enhancement. This technique had been published by Isabella Tomasan-Nagara in Radiology in 2008, where she shows that type 2 and type 3 curves are very sensitive for detection of cancer. The sensitivity is 94%, specificity 92, and the negative predictive value is 90. So type 1 curve would be typical for cystadenofibroma or fibroma of the ovaries, whereas those other curves are typical of either borderline or malignant curves. And I thank you very much for your attention.